Thank you everyone for joining us today. I cannot believe that it is the start of, as Robbie said, after Labor Day, it's fall all of a sudden. It doesn't feel like it in California, certainly for many of us, but welcome to Connecting for Better Health, September 8th. Many of you we got to see in person at Civitas. So that was fantastic. So hello again. And I hope everybody is having a good, grounding back, getting into the groove of things. So our agenda today, we've prepared, I think, a really robust agenda of our guest speaker is Nicole Sweeney with CRISP and CSRI, and will be walking us through their NIH response to an RFI that was recently published. And I think we all are putting some real time and energy into that response, thinking that it will result into some movement at the federal level. So we're really looking forward to Nicole's insight there. We then really want to kind of switch gears a bit and ground ourselves in the implementation of the data sharing agreement and the data exchange framework. We have two speakers that we've asked to prepare some remarks. We would also like to open it up to all of you too, of thinking about how we're going to really implement and get signature on the data sharing agreement. What can we do as a coalition also to be able to help that process? We do want to spend some time, and we'll hopefully reserve some time for all of you to put pen to paper on our virtual survey. We'd love to be able to collect your feedback as we're thinking about programming for next year. So let's make that a priority today. And then we'll just go through some other news and events. And if anybody has any walk-on announcements, please let us know or put it in the chat. I see already that we've started the chat. If you're new to the group, or if you're not, please introduce yourself in the chat. It's a great networking opportunity. We know a lot happens outside of these hours that we are together. So please introduce yourself for follow-up as well. Grounding ourselves on our vision, purpose, and policy priorities. We're a coalition that's dedicated to health exchange throughout California. We really want to see that ubiquitous exchange, and really have the help with that state leadership to be able to guide us as we are all kind of thinking about how we're going to contribute to that success. We're also focused on the policy priorities of funding. And I think as we're rounding out the corner of this year, where we're going to be able to focus on enforcement and governance and compliance now that we have a data sharing agreement. And then if you move to the next slide, Robbie, we also as a coalition are dedicated to 2 priority use cases, just to again ground ourselves. I think it's just so purposeful as we think about these examples of the work that we do both in public health, as you'll hear from Nicole today, and also for our Medicaid transformation and the work that we're doing with CalAIM, and how we need to incorporate whole person care into the perspective of data sharing. So those are really the areas that we want to be able to continue as we move forward, not only this year, but next year as well. So with that, Robbie, I'll have you introduce Nicole, please.
Awesome. Thanks, Timmy. And good to see everyone here again today. I think without further ado, would love to introduce Nicole Sweeney, who is with CRISP, which is the HIE in Maryland, and is here on behalf of another consortium of HIEs or health data utilities who've been putting together a response to the NIH RFI that I think we brought up and discussed. It feels like a long time ago now, about a month ago. Looking for information on how the NIH, as part of its All of Us research program, can better, take advantage of EHR data that comes from HIEs or health information exchange networks. So with that, I'll hand it over to you, Nicole, to provide some introduction and context and a little bit more about the RFI response you all put together.
Thanks so much, and thanks for the invitation to be here. This is really fun. And it's also fun thinking about the fact that it's 11 o'clock there, and I like freaked out at 11:15 when I saw something pop up and I was like, oh no, wrong time zone. So it's good to see you. I think I saw many of you at the Civitas conference. I was the one that did the TEFCA unconference and made you do the sticky notes and various things like that, which is a lot of fun. So thanks for seeing many of you there. So again, I'm Nicole Sweeney. I am the General Counsel and Chief Privacy Officer here at CRISP. And I'm on the senior leadership team for our overall company that is called CRISP Shared Services, which provides infrastructure and expertise to 5 HIEs, including Maryland, West Virginia, DC, Connecticut, and Alaska. I have to count them on my hand, or I don't know when I get to 5. I've been at CRISP NCSS for about a year now, getting close to a year, which is nuts. And before I was here, I did about a decade of work consulting directly for the Center for Medicare and Medicaid Services and SAMHSA and ONC, helping them draft their regulations, first on value-based purchasing and then on the interoperability rules. I did some part 2 stuff, which I can nerd out about for a long time, but that's not what we're talking about today. So I love interoperability. I love regulations. I love info blocking. I love talking about this stuff. So I'm really excited to be here today. And I'm here in my capacity, 1 as CRISP, and 2 as a member of the Consortium for State and Regional Interoperability, which if you go to the next slide, oh, sorry, the next slide. This is who we are. So we're made up of 5 different HIEs that are really committed to taking HIEs from folks that have traditionally very much been used for clinical data exchange to this health data utility model, which I'll talk about in a little bit, just to give you some context if you haven't heard about it before, to think about health beyond clinical data, think about the health of the whole person, and how we can get data from other sources like public health, like consumer generated data, and thinking about the privacy and legal concerns of that, thinking also about how to have governance for that, but really believe that if we're going to make an impact in healthcare, it's going to be because of more than clinical data. It's going to be because we are able to transfer and see these other types of data as well. So that is the CSRI team. And then on the next slide is the mission or the vision, and I'm always confused about which is which, that I just talked about, excuse me. So really, we're committed to thinking about population level health, healthier communities through the HIE, and specifically more about this health data utility model. And if you go to the next slide, talk a little bit more about that. So what is a health data utility? I really like sort of like short, pithy, like you can remember this sort of thing. So when I think about health data utilities, when CSRI thinks about health data utilities, we think about an organization that makes sure that everyone gets the data they're entitled to get, no more and no less, while specifically upholding principles of governance and privacy. So there is not one organization that is getting all of the data and clinging to all of the data and making individual data use agreements with everyone for clinical data, and then another organization doing that for social data, and another organization doing that for Fitbit data. You can have sort of a one-stop shop to get this data from a not-for-profit entity that is not thinking necessarily about how to monetize this data, but thinking about how do we get these data to the right people to make the right decisions based on the entire ecosystem that the person lives in for their health. So health data utility, if you were at the Civitas conference, folks talked about it a lot. You probably heard it a lot. It's becoming one of those things like policy. When I say I'm a policy expert, I'm always wondering what people think when I mean that. It's like sort of one of those words that means nothing and everything. And we are trying at CSRI to really think about what it means to be an HDU, what it meaningfully means. It's a terrible sentence, but what it meaningfully means to be an HDU. So there are kind of three big things that we think about. One is that it's locally governed. I think we all saw from the pandemic, and you all know from working in California, I'm always shocked at the number of jurisdictions in California, but it's like 11 billion, right? And each one of them has their own laws, they have their own stakeholders, they have folks that are going to be interested in various things and worried about various things. And it's very difficult for an overall governing entity to understand the concerns of those various stakeholders. So we really believe that it's important that there is a locally governed, that HDUs are locally governed, so they can understand their state privacy laws, they can understand what their stakeholder needs, and they can interface with other HDUs and with the federal government, excuse me, but while keeping their local stakeholders in mind. We also believe it's a public-private resource, so that public entities, private entities can be coming and getting the data. Again, everybody that is entitled to the data gets it, no more and no less. And it is entitled specifically to build healthier communities. So we have a much larger white paper about this, but if I boil it down, those are sort of the big bullet points. And I think really the green in this slide is, I think, the big takeaways, right? Everybody gets the data they're entitled to. And also, this is going beyond the traditional HDU model to really think about all aspects of health with the person at the center and health equity. And that's really what we mean by health data utility. So if you go to the next slide, this is a bit of an eye chart. I am not going to go through this, but it is here if you want to take a look. These are different examples that we've provided previously as part of CSRI of what we are doing to, as individual HIEs/HDUs in our states to further the HDU model. There are lots more examples, one of which I'll talk about today, but there are a few here if you're interested in the health data utility more. And on the next slide, one of the really, I think, interesting opportunities for health data utilities and HIEs that want to go beyond the clinical context is for research purposes. And I think we all know that there are large gaps in research data sets. You kind of have what you have a lot of the time. Sometimes there are things that are self-reported, and it's very burdensome for research entities to go out and get this data, to track it down from providers, even when consent is, even when the patient consents, and hopefully the patient, consents for all of these things. So I think it's really exciting that NIH specifically put out an RFI that asked how HIEs could be helpful in research with the All of Us campaign that the NIH leads. So this is very specifically patient consented individuals that are like, yes, I want to be a part of this. I want to be a part of your research community. And the NIH has gaps in the data that they need. So the NIH, again, very specifically in their RFI said, hey, you HIE, it wasn't even like buried. Like, this is like the whole point of the RFI. It was very exciting. Like, you HIEs out there, we think you're a resource. Tell us how you can be a resource. So it's such, like, I told you I'm an interoperability nerd. Like, I'm literally getting goosebumps from saying that sentence because it's so amazing having been a part of this community and seeing it evolve, that like we're specifically being recognized and called out. And I had to, I'm going to read this quote. I hate reading off the slides, but I had to put this quote in that was from the NIH's press release that says, HINs and HIEs have been most widely used to share EHR data for patient care, public health surveillance, emergency services, and patient requests, but they can be used for additional purposes. Like, that just got me so jazzed. Like, the opportunities are endless here, and folks at the federal level are realizing that. So NIH is specifically, again, calling out research, and they ask lots of questions. They ask lots of questions in this RFI. How can HIEs be helpful? What kind of data we have? How we can respond? Like, Are they flat files? Could we do FHIR-enabled APIs? What privacy barriers there might be? It was really comprehensive, and it was fun to respond to. So we talked about a lot of different areas that we thought HIEs and HINs and hopefully HDUs, as we get talking about those, could be helpful. One is that HIEs and HINs are great at patient matching typically, much higher rates than other sources. So it might be easier to get the data from us. So that's sort of just like an initial thing, right? Come to us, we might be able to find it a lot faster than other folks. And again, I want to be really clear, this is all with patient consent. So another area that we can be really helpful is, as part of our patient matching, we have lots of demographic information, and especially as folks are looking at measures of equity, being able to match up race, ethnicity, income levels with the patient, which might not otherwise be a part of a record, or might be missing in a record, or might have conflicting information in the record. And I will, sorry, I'm just looking at the chat. I will post the RFI press release before I leave so that you can see it. So even just providing that would be a huge value add. But HIAs can go beyond that. We can provide the records that they want with patient authorization. We can provide population level data analytics. This is something Chris does for Maryland. It's something CSRI has done for COVID with ONC, providing some dashboards on vaccines and various things like that. And we could also help potentially with the HIPAA authorizations. That can be a huge lift. So just as a database, I think most, if not all of us, deal with opt-ins and opt-outs. HIPAA authorizations are a little bit more complex, but it might be something, you know, that we could potentially help them out with. So that was our main response. It's a lot longer. Those are sort of the top line talking points. And the next slide, I wanted to talk a little bit about CRISP and how we do some of these things. I think one of the great parts about CSRI is that, you know, we are a diverse law, and we have, you know, different state level agreements. That's the whole reason and importance for having HDUs be locally governed, is that everything's a little bit different everywhere. So at CRISP, we actually have, as part of our participation agreements, the permitted purpose of research. I will say that this is for CRISP Maryland. DC HIE regulations specifically state that research is a secondary use that is not permitted for HIEs at this time. So I wanted to specifically call out that local laws and regulations might limit some of this, but from the CRISP Maryland perspective, part of our participation agreement includes research as a permitted use for the data that all our participants sign. And I'm sure, as all of you know just as well as I do, right? Like, none of these data that we collect are our data, right? Like, we only get to use them with the permission and as the participants tell us how we can use them. So we're very lucky in Maryland, and that research is a permitted purpose. And then we have these two kind of overall umbrella use cases. And if something fits within this use case, it's more or less approved. It's a little bit more complicated than that, and we provide transparency and report out on these things. But if we get a request for a research use case, and there has been patient consent with HIPAA authorizations, and the research case has been approved by an IRB, then that falls within one of our use cases, and that's a permitted purpose under our participation agreement. And then we also have a use case for MPI and demographic enrichment. What I was talking about before, that's an explicit use case that we have, that if somebody has a previous existing research case, or there are some data analytics that folks need, and they need to enrich it with our MPI data, that's something that we are permitted under certain circumstances to do. So if we wanted to do more research as HIEs, you know, we would have to think through, if you haven't thought through already, your participation agreements, do they allow for research? You know, do you want to have use cases that are approved as one-offs? Do you want to have sort of like we do at CRISP, these umbrella use cases? What is going to work best for you in your state and jurisdiction based on your stakeholders? I think another thing that we think about with research and with this NIH RFI is identity verification too. Who's going to be doing the identity verification for HIPAA authorization, and that can sometimes be very costly. So something to think about as well. And then I already mentioned thinking through local laws and regulations. Is research permitted if you have HIE regulations? Are there other laws or regulations that would prohibit the use of your data for research? So I think I had 15 minutes. I think I got pretty close. So my next slide is just if folks have any questions. I'm not sure if we have time for them, but if we don't, my email address is there. Would love to take any questions about this, or like if you're an interoperability nerd, my husband is really sick of me talking about interoperability and would prefer I talk to people about it who care. So if you're interested, please let me know.
Well, no, thank you so much, Nicole. And I think it's exciting to see the NIH A, look for other sources of data, but B, looking to HIEs for that. I think one question that comes to mind, I think that connects with Robin's questions in the chat around like SDOH or SOGI data. Was there anything you offer in the RFI response around how to maybe think about how to combine health and social needs or SDOH data as part of the resource that HIEs or HDUs can provide to NIH? I have to imagine it's often probably difficult for them to gather a lot of social needs data, but I'm curious if that was part of your response at all.
Yeah, I believe we specifically called out that don't reinvent the wheel on social data, right? Like you've spent so much money on HIEs. We're already collecting so much of this data. Like we can fill gaps. We can provide our clinical data sets as well as social needs data sets. Or assessment at CRISP, we have some SDOH assessments as well. So I don't feel like that answer is comprehensive, but we definitely said within the RFI, use us for more than clinical data, right? Like through this HDU model, we are collecting social needs data. We have a lot of it already. Don't go out there and do it again. Use us.
Definitely. No, thank you. And Robin, I saw you had your hand up. Did you want to ask another related question?
Well, actually, I think the question, or I should say, Nicole, I'm not sure the answer was really related to the SOGI data part of that question. So let me be very, very concrete. A lot of provider organizations, MCOs in both medical, behavioral health, and substance abuse services are really not identifying those data elements, and wondered if you did include that in your application or your response to the RFI. And in particular, is CRISP as an HIE and any of your participating entities in the states actively collecting that data today? And it's really couched under the health equity umbrella.
Yeah, so let me see if I can answer this. So I'm not sure if we specifically said anything about the SOGI data. I will say that from the CRISP perspective, we got a lot of bang for the buck for the immunization data, for the COVID immunization data. We were able to do a lot of social data based on the self-reported data that was a part of signing up for immunization. So that is something that CRISP has, and we've been enriching our data sets with that. But I'm not sure to the extent, and I could find out for you, I'm not sure to the extent that our providers are actively reporting that data, or if they're reporting that data, if it's accurate, to be frank.
And I guess really the question would be at your level too, are you able to aggregate it? So sexual orientation, gender identity really is a demographic question. So I'll leave it at that. I think it was just, was curious because you mentioned the importance of the health equity component, and if that's something you all have identified. So I'll let others speak. Thank you.
Sure, and I don't feel like I answered your question. So if you want to try to talk offline, I'm happy to do that.
Thank you.
Great, and I think just a couple other questions. Does Chris support patient-mediated granular data sharing as part of consent?
So like individual elements that we're
Mhm.
talking about. No, at this point, it's sort of like an all or, it's not quite an all or nothing. We have a couple of options, but it's not, you know, this part of my record for this part. That's definitely something we're thinking about in the future, but we're not there yet.
Great. And one other question too, I think just around, you know, the intersection of HIEs and research is around, you know, the IRB process and who's engaged in your IRB process? How are you getting consent for the use of aggregated data?
That is a great question. And we made the strategic decision a long time ago to kind of rely on the IRBs of others. So basically what we say is if you have an IRB and you can show us that your IRB approved this and you have the appropriate documentation, we are going to rely on that. And we are not going to conduct our own IRB. We don't necessarily have enough knowledge about like what you are going to do and how you're going to move forward. So we rely on their representations, and that's what our use case says.
Great. And any other questions any folks have at all?
Robbie, I have one. Just Nicole, in terms of the RFI, is that something that you can make public, or is it something that
let me ask, I don't see any reason why we couldn't make our responses public, but let me just ask everybody else.
Sure.
The RFI is out there. Unfortunately, for those of you who didn't know about it, I believe responses were due at the end of August. But I will put it in the chat so you can at least see what folks were asking. And I believe the government is going to do some type of, you know, like this is what people said sort of thing. And I think, you know, even if you didn't have the chance to respond, it shows that the NIH is interested. And I think, you know, it shows a reason for us as HIEs to be asking for meetings and saying, you know, this is obviously something that you're interested in. Can we talk to you more about it? So don't worry.
I think it opens the door, right?
Exactly.
It's going to meet the deadline, follow up.
Yeah, exactly.
Well, that would be great. I just think that the more that we can consolidate kind of where this great thinking is and learn from each other, it's always fabulous to be able to have that kind of opportunity.
Excellent. Well, thank you so much for joining us today, Nicole. Really appreciate your time in the presentation.
Thanks
And
so
Nicole,
much.
could you put your email just in the chat too?
Yes, absolutely. I'll put the link and my email in the chat and look forward to talking to some of you.
Great. Thank you so much.
Excellent.
And Robbie, I think we're going to switch gears just a bit and move on to the implementation of the data sharing agreement.
Yeah, I think, switching gears from research back to California and the data exchange framework, you know, we know 2023 is fast approaching, you know, for many organizations who are required to sign the data sharing agreement to do so here in California. And, you know, wanted to start having these conversations here around what are stakeholders thinking when it comes to signing the agreement, what issues with compliance might be coming up, you know, how are folks thinking about, you know, compliance in terms of weighing that with, you know, the lack of penalties, to be quite honest. And, you know, maybe what interests do other organizations have when it comes to signing the data sharing agreement who may not be required to right now. So I think we'd love, you know, to have a little conversation here. I know we reached out to a couple of folks ahead of time to share their thoughts. I don't know, Deanne, maybe do you want to kick us off with, you know, a CPCA Health Center perspective around the data sharing agreement and, you know, how your constituents are thinking about, learning about, and assessing the data sharing agreement at this time. Deanne, are you on the line? I see you're on. All right, well, I will turn to Andrea first, because I know I reached out to you ahead of time too, Andrea. Welcome, welcome. You know, from a healthcare attorney perspective, you know, who has lots of healthcare clients, how are you all thinking about the data sharing agreement?
Yeah, and I guess just for context, so I work at Hooper, Lundy and Bookman. We exclusively represent healthcare providers, so hospitals, health systems, and physician practice groups and the like. So very much kind of a provider focus in terms of the comments that I'll be giving. But I think as an initial matter, a lot of our clients aren't even aware that this has gone into or will be going into effect soon. I think a lot of folks are starting to catch on that the DSA is just finalized and the implementation requirements that are upcoming. But certainly it's something that I think has given a little bit of a heart attack to some clients of, oh, what, this is already so soon, and we have these obligations that are upcoming. And then I think on top of that, for folks who are kind of on top of the requirements that are set out in the DSA, we hear a lot of concerns and sort of complaints around the more heightened obligations that the DSA imposes as compared to, just standing privacy requirements under HIPAA and California's kind of analogous law, the CMIA, particularly around breach notification requirements, and then just the treatment of data that falls outside of PHI, but is considered personal information, and the extension of for example, the security standards under the DSA to personal information, not just protected health information. So I think, those are big areas of concern. And then from other subsets of clients, we've also heard kind of concerns around the treatment of more sensitive health information, and whether or not there's kind of more thought or concern as to, for example, reproductive health services or certain, HIV mental health services information. So I think that's another area that's given some clients concern as well.
Mm-hmm, mm-hmm. Are there any, I guess, other needs that have maybe come up in the context of this in terms of, need for technical assistance or funding, or even, I know Cal HHS, and we'll announce this shortly, is going to start having some intro webinars, but is there any need, from the state or, other organizations to help with, education or kind of assessing policy needs around this work?
Hearing from a couple of smaller provider practice groups, I certainly think there's a need for both kind of technical guidance, and then funding as well could certainly be of assistance for smaller, often nonprofit entities. So I think those two are certainly areas worth exploring to really be able to on-ramp a lot of providers. I think that's less an issue for bigger health system clients, particularly those that are already subject to information blocking rules and whatnot. But it is, I think it would be a welcome thing from many of our clients.
Mm-hmm, mm-hmm. No, that makes sense. Do any other folks maybe have any other thoughts too around, maybe what you're hearing from your members or constituents when it comes to the DSA at all? I think Andrea, you raise a lot of great concerns that I think we, mentioned in our comments too around, the breach notification issue, some of the definitions around personal information, and, hopefully in some of the forthcoming stakeholder, groups around the PMPs and such, some of those issues hopefully can get resolved or mediated, aligned with state law, or, figure out how we can, make sure that everything aligns when it comes to the DSA and statutes as well. Deanne, good to see you.
Yeah, I was on, but it was that hidden mute, like my phone was not muted. I was logged in, but oh well, here I am again.
No problem, no problem.
From the FQHCs, there's a general lack of awareness, and I'm doing some messaging. The health center controlled networks, which are typically affiliated with the regional consortia, they're aware, so they're messaging to their members. Many who are aware are not overly concerned because they are doing a lot of data exchange. Many utilize their regional HIEs, and the ones who, especially this past spring, were reviewing the draft of the data sharing agreement. Despite all the time and energy that was put into creating the data sharing agreement, could be a good thing, bad thing, the outcome. A lot of feedback was, it's another data sharing agreement. So the good news is they were like, it's another data sharing agreement. It's not scary. It's not this. Bad news is, will it drive any change if it's the same old DSA type of thing? Definitely intrigue about the non-HIPAA compliant entities, how that will play in. And according to my personal read of AB 133, there is to be technical assistance funding for all of the entity types, not a carve out. And I don't know right now today what funding in the 22-23 enacted budget landed on the data exchange. Like what hit, what is in the budget? I don't know that. I wish I knew that. So maybe somebody here knows it. And who is it for? But education and outreach, which there's a webinar next week that I think, Ravi, you're going to show or share, and discussions about funding are in sight. Signing by January 31st is what I'll be driving FQHCs to be aware about and doing. I mean, a lot of people ask the first question, I'll stop after this one, of there's no signature block on the actual DSA.
Deanne, that's brilliant. Brilliant contribution.
A little bit of a barrier. Now, I responded to a couple people, well, maybe because it'll be electronic, you know, that would fit, but I don't know. So anyway, lots of different stuff. None of it's horrible. But where's it going to go in the next couple of months is interesting, and we're interested to see and to play a part.
Yeah, and I guess one question: have there been any similar concerns, like you know, some of the ones Andrea raised around, you know, some of the changes when it comes to, you know, breach notification, and you know, some of the definitions used in the DSA too. Have you heard any of that from your health centers at all?
I wish I have, but I don't think they're that far into it. They're not deep enough to truly have expressed those concerns.
And in terms of some of the, you know, around like technical assistance and funding and such, what would be most helpful when it comes to health centers, and, you know, maybe, you know, making sure like all boats can rise, so to speak, you know, so that folks are able to share data? What are some of the needs maybe of the neediest health centers?
Well, needy or not, and at least a decade into it, health centers want a workflow. They show me the workflow, and that falls under technical assistance. Here's step 1, step 2, step 3. This is the recommended workflow, and then of course anybody can customize as needed. And then I also think of, and I hear it often, the exchange of data with the managed care plan. That's huge. So I think everything under the data exchange framework is on the right path. I worry a little bit about some of what I'm seeing in the implementation of CalAIM that still seems to, and I could be wrong, seems to allow the health plans to all have their own individual approach, which that is yet where it's all heading, is the exchange of data. So I think that's a really important part where technical assistance funds and a brain trust is working on that. And it ties into IHA and EDGE and counter data, like here to from the providers to the managed care plans to the state. How is all that data flowing, whether it's via an HIE or not. And duplication of efforts, triplication. Are they reporting to the health plans? Are they reporting to an IHA or somebody? Are they reporting data to their HIE and then through to something with, and then somebody else is coming and asking to share in top health management service that's unfolding? People are worried about duplication of effort ×4. Yes, the whole thing should be streamlining it all, but we might have a bit of a summit to get over. Any thoughts or responses to some of what I rambled about, anybody?
I mean, I think your last comments really resonate at least with I think me and Timmy. And some of the feedback that's been provided right over the past year around, how do we align the data exchange framework with CalAIM, with the population health management initiative, and make sure it's all seamless and reinforces each other rather than kind of exists in silos. And I think that speaks to the issue you raised when it comes to creating policies in CalAIM, Pop Health, and then now the data exchange framework that might be a little disjointed. Doug, I see you have your hand raised.
Yeah, Robbie, as you know, I worked with a very large MSO and worked aligned with the health plans for capturing this information when it came to our HEDIS programs and case management programs with the community health centers and FQHCs that we supported wholeheartedly. And there is a lack of understanding, and I concur with what you say. The part of it is the issue is there's no consistency with the federal requirements or even the state requirements for ensuring that they're capturing the right data from those patients. There's no consistency with actually getting the correct phone numbers for the patients from the state, from the Department of Healthcare Services when they sign those people up. And so we have large gaps of information from the get-go. And so until they address that, it's hard to circle it back at the end user point where we can get those correct CPT codes and exchange information into an HIE. So we have quite a conundrum with that.
No, that's helpful, Doug.
And I think we've heard, and we will continue this thread, I think, in our meetings going forward too, is be able to get different stakeholder perspectives on where they are in the review and signing of the agreement, and loud and clear the managed care plans to play such a large role. Back to you, Robbie. Sorry, I see more hands up.
Oh yeah, no, I was just gonna say, I think to your point, Doug, that raises for me the issue of how do you also enforce standards, right? So we can promulgate them, but how do we make sure everyone's utilizing them, right? And maybe that can.
Well, it starts with the HRA. I mean, we don't even get HRA on and FQHCs are required to assist with the HRA, and so are the health plans, but we can't even get consistency. When we look at the numbers, the percentage of HRAs that are done in the beginning of the year is pitiful. And so that shows the initial breakdown of lack of information that we get from the state as far as the information on the patient data. And then when they actually make it to that practice and into that FQHC, then getting the proper people giving that information in the proper format. And there is, you can walk them through the workflows, but there's just inconsistency with staffing. We deal with some FQHCs that are, like 80% volunteer employee. So how do we get consistent with when it's in a volunteer staff that will maybe show up one day or maybe not?
Felix?
Hey, thanks, Robbie, and thanks, Deanne, for I think teeing up some issues that we're all agreeing are ripe for discussion. It probably ultimately suggests that we should really actually carve out some time separately to brainstorm and try to troubleshoot But I'm heartened to hear that a lot of your members, the clinics, especially the ones that are affiliated with the communities, the health centers, they're kind of like tanned and relaxed, right? They're kind of like ready for the yet another DSA to sort of fall into their laps and to comply with. That being said, like what you really said struck me about workflows. You mentioned that a lot of the clinics are intending to use their regional HIEs to comply with AB 133. And speaking as an HIE, speaking as a member of KHI, that's obviously really encouraging for us. But you also said that the sticking point seems to be this issue about just the various ways of exchanging data and getting data from the Medi-Cal plans. Again, I think ultimately this behooves like a discussion between KHI and CPCA to try to really maximize the opportunities to add value and to support your organization's compliance. But yeah, I'm just curious, like as one example, like do you find that the clinics are trying to figure out ways to send not just like encounters to the Medi-Cal plans, but also like clinical data? I just would like to sort of probe that some more and maybe sort of again also pin it for further discussion.
Yeah, well, they might have 5 different or 7 different, an FQHC HRA template that their various plans or IPAs require of them. So Kaleem is trying to clean that up, but we're not there yet. And that's where, like, is someone actually doing the data entry of an HRA that goes to one health plan? And how does it go? Is it going? It's kind of still going through something that's equivalent to a fax, probably. Is it digestible, structured data? So, the framework is necessary to get us there. The middle bullet here about the non-compliance and lack of penalties, like a lot of people, not officially from any FQs I've heard, especially recently, but there's no provider penalty under the 21st Century Cures information blocking. We're still waiting for that. And until the same thing happened with meaningful use, until the penalties came, certain groups of providers weren't going to become a meaningful user. Why they forewent the incentive years, who knows? But it wasn't until they started getting a ding that the phone started ringing, saying, okay, I'm now getting a penalty. How do I do this? And I'm like, well, that's based on 2 years ago, so you can't fix it for tomorrow type of thing. So unfortunately, penalties do resonate. And I think a lot of entities are not compliant with 21st Century and 21st Century Cures Act because we're still waiting on if or what the penalties are on that.
Yeah. I don't think any of us on this call can speak for the state in terms of, what may be coming down the pike in terms of enforcement, but that point is well taken. Obviously, we're all waiting to see. I think that's obviously a topic to be determined in the next phase of the DXF planning process. I think in the immediate term, though, like to the example of HRAs, just and just the different ways of analog versus digital in terms of sending the information to the plans and getting it back from them. As a macro point, again, as you know, the HIEs, we serve both ends. We're proud to count both the Medi-Cal plans as well as the FQHCs as data participants and partners in our networks. So I think there's a real potential to kind of be the connective tissue to simplify and streamline some of these issues. So yeah, just definitely just a pin to talk more and hopefully soon.
And I do think one thing too I might mention is I do believe in the population health management strategy DHCS has put together. They are looking to align the screening tool used to assess for health risks that's utilized by all the managed care plans through that work, and kind of retire the staying healthy assessment and the IHEBA they're using right now, and switch to a separate tool that all the managed care plans would have to utilize, which I think also speaks to their population health management solution, which, will is required, under the RFP that went out to be able to, collect all of that data from managed care plans and providers as well.
That for the crowdsourcing of this group, does anybody know who was awarded? DHCS sent out a stakeholder news this week saying we have awarded, but they don't say the who. Unless I've read it 15 times and have missed it.
Yeah, I think we heard that it was Gainwell Technologies. And we can put a link to that.
No, you're right, Deanne. They didn't list it and didn't put on their website either.
Thank you.
Yeah.
Mhm.
Well,
Was anybody involved in that RFP that's on this call? Were you involved as a supporter?
Who were you asking?
I was just asking if anybody on this call was involved in the RFP response that was the awardee. We'll get more. We'll follow up on that.
The one that you guys sent out, I think a lot of us here chimed in on that.
No, this is the population health one. So the award was made, DHCS made the award this week. And I was wondering if there was any stakeholder that was engaged in the winning.
Oh, yeah. No, we're in the audience.
Okay. Yeah, and I did follow up with John Ohanian right away, because I hope that it's on his radar too. But let's keep following it as a group, because I think it's a big investment that the state's making and will have impact.
Yeah, I mean, it's finally they are making a huge investment, and I think it's a step in the right direction. I have no fiduciary interest in anyone that's doing it. It doesn't matter to me. It's just a matter of getting the patient's care at the right time and getting them engaged with, let's not have a watered down health plan for these patients. Let's have real health care for them.
Yeah. Agreed, Doug.
Excellent. Well, thank you so much, Deanne, Felix, Andrea, Doug, and everyone for your thoughts on this. I think what we can do is, continue this conversation as the first of the year nears, and I think continue to kind of crowdsource ideas when it comes to what are some of the challenges to signing the DSA, or some of the related issues that stakeholders are raising as well.
Yeah, and please raise your hand, reach out to us outside of these meetings too, and we'll reach to be proactive, reach to other different stakeholder groups to be able to get, the pulse of where there might be some, additional insight as we start tracking signatures.
Awesome. Well, Timmy.
Here's our survey. I think I gave everybody permission to multitask. If you could please go ahead and a survey, I think, Amy, if you could put the link in one more time, that would be awesome. And if you could just click on that, it'll take you 5 minutes. I'm trying to give you time to click on it right now and fill it out. And you'll notice one of the opportunities you have too is for us to collect more stories, and we did that last year. It was super successful. So if you or your organization has additional stories that you want to tell, we will follow up and give you resources to be able to mine those stories, so that we can continue to be able to highlight those not only in these calls, but as we rev up for what we know will probably be an active HIE/data interoperability year next year too at the legislature. So please take a moment to do that. And we really appreciate your input and your support as we go forward. Okay, I think I filled the 5 minutes while you guys were all doing that. Right, let's go ahead. Yes, thank you, Robbie.
Yeah, I think just just a reminder again, if you haven't done so, please register, download the meeting series, feel free to share the link with others. This will get you through the end of the year. Just a reminder to folks.
And
then,
Robbie and I are also, let me go back, Robbie. I think either one of the November dates will be our policy coalition, our policy webinar that we do. We have done it, I guess, just virtually in the past, but we have found success doing it in Sacramento in person. If we can do a hybrid, maybe that would be awesome. But one of those November dates will be our collection of a policy discussion to be able to get our policy priorities for next year. But please mark your calendar.
And relatedly, mark your calendar for these upcoming Cal HHS events as well. These were emailed out by CDII yesterday, but just these three. One is a webinar next week about the data exchange framework and really an overview. The other two are, the interim committees that will be providing input to Cal HHS on, further amendments to, the DSA or generation of new PNPs. So the first one's the Implementation Advisory Committee meeting on the 21st. This committee, I think, is kind of the new iteration of the Stakeholder Advisory Group. I don't think the names of everyone have been listed yet. I think some of you on this call are on that committee, but this will kind of serve as that interim, primary advisory group. And then similarly, there'll be a data sharing agreement policies and procedures meeting on the 23rd. That'll continue to churn out new PNPs, and some of those were identified in the last meeting deck that was produced for the advisory group, identifying some of the immediate needs when it comes to policies.
And if you all, whoever gets the list of those who are participants, can you send that to us? I've also requested it from John. And once we do, we'll publish it for all of you, but we're very keen on learning who the stakeholders are so that we can make sure we're engaging them in this work.
And they will be posting the agenda for all these meetings soon, they indicated as well. Excellent. And I guess just other news. So as was mentioned, DHCS announced the procurement of their vendor for the population health management solution. So just as a reminder, that was a $340 million budget appropriation last year for a vendor to assist DHCS with all of their population health management work around risk assessment and stratification analysis as part of CalAIM and now re-procurement. So we'll have some health plans and shifting members, new responsibilities, I think, for the managed care plans as well. And I think in their process of trying to align all of the various initiatives amongst plans. So the press release wasn't put on their website yet, but you can check out the link here for more information on the overall strategy and roadmap. I think too, we're looking to have some more programming this fall around the PHM. So stay tuned for that as well. I think just two upcoming events. State of Reform is happening on the 22nd. So in between those two Cal HHS meetings in LA, Timmy will be on a panel talking about, data sharing in the context of SDOH with some folks. And I know folks from many of your organizations on this call will be there too. Let us know if you'll be there. We can all meet up and say hi. Additionally, Manifest Medics has a meeting a summit at the end of the month in San Francisco. The link is here too. And then a couple other news items for folks. The Office of Management and Budget within the federal government is hosting some listening sessions. They're looking to make updates to federal race and ethnicity standards. So you can find more information through this link and sign up to get more information. We will also send out information on that too. They have sent out some preliminary dates where they will be hosting listening sessions if you're interested. So we'll make sure to share that in our newsletter. And then additionally, just, ONC and HRSA are working to align the uniform data systems that health centers have to report on, aligning that with US CDI to make sure that there's more consistency there. And I think, another news item that we put in our newsletter this week is that Attorney General Rob Bonta has sent out a letter just, days ago to several hospitals across California requesting, more information on the software tools that they're using for things like population health, shared decision-making and such, to understand how they're addressing racial and ethnic health disparities. I think really related to, the ongoing conversation around, the use of, data and data mining tools and how that might be widening, in fact, health disparities amongst groups.
Robbie, I just love that we were able to highlight this kind of this focus and this leadership coming from the state from a different perspective. Almost reminds me of the conversation we had at the beginning of this call, that there's an opportunity, the door is open for all of you to respond to our AG about how your experience and the assets and the resources that the state has to be able to answer these questions. So I would really encourage you to reach out and make sure that your constituents and your clients as well are part of this response. And we can put our heads together, Robbie, on a response as well.
Yeah, we can do that.
Doug said the survey is done. I love that. Thank you.
Thank you, Doug. Thank you, everyone. I think that's it. We're 2 minutes over.
Awesome. And if you haven't filled out the survey, please do it now. We'll see you guys in 2 weeks. I think if probably in person actually at Health Reform, but I'll find an area to be able to join you all. And thank you. Have a great day. What a great conversation. Take care.
Thanks.
Thanks, you guys.
Bye.
Thank you.